We are ready to start the 6th webinar on peripheral nerve diseases with special interest in inflammatory ones. Today we have a very interesting topic with two distinguished speakers. The title is Peripheral Nerve Imaging with Focus on Inflammatory Neuropathies. Ultrasound use will be a talk given by Professor Nens van Alfen from the Radboud University Medical Center in Nijmegen, the Netherlands. I hope the pronunciation is correct because I studied it. And Professor Nens van Alfen is a neurologist and clinical neurophysiologist with a special interest in peripheral nerve disorders and neuromuscular disorders with a special focus on ultrasound. She's the chair of the Clinical Neurophysiology Laboratory and one of the founders of the Peripheral Clinic team in Nijmegen. And she's the current president of the IFCN, Society of Neuromuscular Imaging, and she's also a very good friend of mine. And then we will have the pleasure to listen to the talk by magnetic resonance neurography by Dr. Stephan Goedee, University Medical Center in Utrecht, the Netherlands. So today is Dutch speakers. And he's a neurologist and clinical neurophysiologist at the University Medical Center of Utrecht with a special interest in neuromuscular disorders, inflammatory neuropathies, motor neuron diseases, and he has gained huge expertise in muscular ultrasound and electrodiagnostic techniques, and also in MRI of inflammatory neuropathies. He's serving on the board of National Society of Clinical Neurophysiology. He's a member of the scientific panel of the EAN peripheral neuropathy, and is contributing to as faculty in national and international training courses on neuromuscular ultrasound with important contribution in the study of CADP, MMN, and diagnostic therapeutic approaches for these conditions. So we are starting with the first talk given by Nens. I remind you that this talk is recorded. You can start with your slides, Nels. You will be able to follow all these webinars on the YouTube channel of the EURO-NMD URN. So they are available afterwards. We encourage the dissemination to your colleagues of these important webinars. Okay, ready to go, Nens.
Yeah, thank you so much, David, for the invitation and the Dutch team to enlighten you today about imaging of peripheral nerves. I think Stephan and I, we know each other well and work together. I'm going to present a little bit of his work. I hope I'll do it justice as well. So it's a pleasure to talk to you about nerve ultrasound, as we think it's a technique that really can augment your clinical diagnosis and your treatment plans for patients, especially with inflammatory neuropathies. And that will be the focus of these next couple of minutes. Yes. So first question that I still start with, if we talk about this, is why would you use imaging for the neuromuscular system? And I think at this point, the technique has gotten to a point in time where you could really say that ultrasound is to EMG or electrodiagnosis what MRI is to EEG. You would never not use them both. It's a really useful technique. And you know, if you go to a neurologist and you have a problem in your brain, the first thing that anyone will think of is making a beautiful scan. But there is really no reason why we could not do that for the peripheral nervous system. And we could make equally nice pictures of peripheral nerves, of muscles, and even of contractions or things like fasciculation. So this is the statement for today. Ultrasound is to EDX what MRI is to EEG. They're complementary all the way. It's not about replacing one with the other. It's about getting the best technique for the patient that you have in front of you and you want to help. And really, to me, imaging is, in addition to the EDX, it's like this Swiss Army knife tool. It's a jack of all trades. There's a lot of things you can do with it. So you can assess the tissues for abnormalities, and you can look around a lesion to see if there's anything that impairs a nerve. You can screen a lot of body regions in a relatively short time, and it usually is not painful unless, you know, the patient has pain because of a trauma, etc. The nice thing is it's also dynamic, so you can capture movement, not just muscles, also nerve, for example, gliding in the carpal tunnel. And it can really help you guide your invasive procedures, like sticking a needle in or doing a biopsy. And the good thing about it is, because imaging is a new technique compared to EDX, there's been a lot of research going on, and there's a lot of, you know, evidence by now about which disorders it's very helpful in, and also about disorders that maybe you should stick to EMG. So if we look at nerve ultrasound, there are a couple of context factors that you know, determine whether you're very good at what you're going to do. And I think for me as a neurologist, one of the first things I had to relearn was anatomy, peripheral nerve anatomy, in the context of the remainder of the limb, so the muscles, the bones, the fascia, the tendons, etc. And the other thing that we would really argue for you to do is not just scan protocol sites. So we know in the literature, when you look at research, everyone will have to make a reproducible protocol that they put out into a research paper. And that standardizes measurement sites. For example, carpal tunnel, you measure between scaphoid and pisiform. But if you go to a patient in the clinic in a real life scenario, you want to scan the whole accessible nerve length, because you will never know upfront where the lesion is going to be. And if we talk about simple carpal tunnel diagnostics, 20% of the entrapments is actually in the distal segment. So you will miss that if you only stick to one protocol site. And then I think what makes us different as neurologists scanning from, for example, radiology, is that we do not just eyeball a nerve. We also measure it. We give it a number, we use a reference value, and that makes us very sensitive in detecting pathology, more than just looking at it and, you know, having an opinion. But also, if you are the one scanning with your patient, don't stop being a doctor. Just use the ultrasound as an extension of your clinical exam. So also take a focused history, maybe a short physical exam to corroborate your ultrasound findings, and then integrate whatever you see on the screen with that clinical info so it matches up. Now, here's a very short practice example for those of you not yet familiar with the technique. We created this for a course a couple of years ago. It's just a basic scan example of an ulnar nerve in the upper arm. As you can see, the nerve is actually there, just underneath the fascia of the triceps, the medial head. And you can scan it up and down. You can see the subcutis next to it. There's also another nerve right there and branches here. That's the medial antebrachial cutaneous. You can turn the Doppler on like this and see that there's a small vessel next to the ulnar nerve. It should be here. And then if you freeze the image, you can take measurements. And then we agreed that if you stop the image and you want to take a measurement, you will do so within the epineurial rim. So here we're going into the sulcus at the elbow level. You can still see the nerve there. The sulcus is a very bouncy and bumpy ride for the ultrasound probe, so it takes a little bit of juggling with the probe to follow it. But here we're in the forearm entering the cubital tunnel beneath the flexor carpi ulnaris, and you can see the deep flexors there, for example. So it gives you a beautiful overview of the anatomy, and you can just look at the context and see what's going on. Now, when do we call a nerve abnormal? Well, this is a zoomed-in image of, I think you will recognize the nerve by now. This is the median nerve in the forearm between the superficial and the deep flexus. And right above it here is the FCR tendon. And if we measure it, we do so within the epineurial rim, like that. We call this the cross-sectional area measurement, or CSA. And the reason to measure it within that epineurial rim is because epineurium will transit, like this white layer around it, it will transit into fascia and epimesia around muscle. So you don't know where the actual border is. So this is the international definition. Now, if you've never seen a nerve and you don't have a bunch of reference values yet, I think this slide could go a long way for you in a normal adult population. So these are the average sizes for adult nerves, where you see that, for example, the arm nerves are slightly smaller overall than the leg nerves, There's more connective tissue in your leg nerves. There's more gravity influence probably. You see that the sciatic is kind of big, but it's actually a combination of peroneal and tibial, or fibular and tibial, if you will. And you can also see that any sensory nerve in the subcutaneous layer, usually the main branches, are anywhere between 2 and 4 square millimeters. But you don't need to go about collecting all these reference values for yourself. There's a lot of references out there already. This is 3 meta-reviews and meta-analyses from a couple of years ago. And I can recommend this sort of publication for you to just look it up if this is the actual population that you get in your clinic. If you get people from another continent, you might want to search for those references, but there are plenty available, both for adults and for kids. So let's move on to the topic at hand. How could you increase your diagnostic accuracy for inflammatory neuropathy? Because that can be quite challenging in practice. Well, if we look at the typical ultrasound findings of things like CIDP, chronic inflammatory demyelinating polyneuropathy, or multifocal motor neuropathy, which is sort of its cousin, you will always see that the nerve becomes bigger and that the fascicles will expand in size when they are inflamed, and they may get some grayish interior that is probably either edema with protein or fibrosis if it's long-standing. Now, and this is a short video of an ulnar nerve, again, the one I was scanning just now. For your reference, this is the skin layer on top. Here you see the subcutaneous layer. The black stuff is fat. The white wavy lines are the lymph channels. And you see small sensory nerves like this one or that one and an occasional blood vessel. Then you have this big white line here, which is fascia over muscle. And in this case, it's the triceps that you're looking at, the medial head. And here in the deep area, you see the bone, which is the humerus. Now, the nerve is going to be here. And when I start the video, you can see it enlarge there, like balloon up. And those 2 fascicles that you're looking at now are really big, and they are filled with this ground glass grayish material. So that is what inflammation can look like. Now, in its recent iteration, the EAN and the PNS have revised the CIDP guideline, and I think my colleague that will talk about MRI was a part of this revision. And in the end, after looking at the evidence, the task force suggested that ultrasound is actually good as an added diagnostic tool if you have a patient with possible CIDP, but the other tests like the electrodiagnostic tests cannot get you to the level of certainty for the definite diagnosis. So in that case, ultrasound is really recommended. And you don't need to be very extensive. Just scanning the interscalene region of the brachial plexus and a median nerve in one arm already gets you a very high sensitivity. And of note, if you look at inflammatory neuropathies, then the takeaway would be that ultrasound is quite sensitive for these abnormalities, but EDX, electrodiagnosis, is the specificity that you will add. So which type of neuropathy am I looking at? Now, there's another small part in this guideline that says the task force suggests that you not use MRI to diagnose CIDP because, except maybe for you don't do this at all because MRI is not sensitive enough, right? It gives you a beautiful overview of the nerves, but it doesn't have the level of detail in a routine scan. If you are lucky and you have a radiology department that does MR neurography, you might be able to see the abnormalities, but routine slices like in cervical spine or routine brachial plexus are usually not good enough. So let's go back to the ultrasound then. Here are a couple of examples that I'm going to show you that come from patients with CIDP and MMN. And really, it's a game of bigger, and the biggest nerves. So on the left, you will see a normal nerve at the same location. So in this case, median nerve here beneath the transverse carpal ligament. This is the ligament right there. That's the nerve with the measurement. And the measurement is 8 square millimeters. That is within normal range. A normal nerve in our lab would be smaller than 11 square millimeters. If you look at that nerve in the person with CIDP, then you will see that here it's slightly more proximal, it's the distal forearm. The cross-sectional area all of a sudden is 22 square millimeters. That's almost 3 times the normal size. So that is a case of inflammation and nerve enlargement. Now, if you wouldn't use the reference value, looking at this nerve would not definitely tell you that it is an abnormal nerve, right? Because it still has a fascicular structure. It's not, per definition, very hyperechogenic or hypoechogenic. So you really need those numbers to say that this is definitely abnormal. If we move ahead to bigger, here you see the ulnar nerve that you've already seen just now. This is a normal looking ulnar nerve with a cross-sectional area of 7 square millimeters. I've highlighted the nerve here. You can see the difference. The depth gauge is the same in these images. So on the left is a normal nerve, and on the right you see that big swollen ulnar nerve with a cross-sectional area, in this case, of 64 square millimeters. That is almost, no, it's more than 8 times, 9 times the normal size, really big. But you can do even better or worse. So this is a sciatic nerve at the back of the knee. So this muscle on top of it is biceps femoris, and you see the sciatic nerve right there, 38 square millimeters, that's normal. Anything between 35, 40 square millimeters, just normal adult size. If you look on the right, it's really hard to see the sciatic. You know, everything is stripes, and it actually looks like part of the biceps femoris. But if you move this image, you will see that this is the sciatic, and it's gigantic. It's 131 square millimeters big. So really big nerve right there, also as a sign of this inflammatory neuropathy. Now, there's always a bigger boss, as we say here. This is a publication by a colleague of ours, Paolo Reppellino, who is in Switzerland. And he found patients, and we've seen them as well, with gigantic nerves. And this is just a still image. You can see them in the transverse, but also the longitudinal sections. But he has a few videos in there, and I've asked him if I could copy them. That was okay. So you're going to see a very, very big nerve right here. So this is where the patient will be scanned from the wrist, which looks normal right there. And then we're going into the forearm, and all of a sudden you see the nerve swell up, and then all of a sudden it fills more than half of the forearm compartment, really large. So this is probably a very active acute stage for this patient. You also see that the fascicle size changes when you move from distal to proximal. That is very common also for the CIDP. So that they might be gigantic. The nice thing about the ultrasound, though, we already talked about it a little in the protocol, is that it's, with a little bit of practice, it's not that difficult to scan the very proximal parts of these nerves. So this is the supraclavicular brachial plexus. I've tried to outline the anatomy for you. Basically, the probe is just over the clavicle in the same direction. And you can see the first rib right there. You can see the edge of the lung, so the pleura. On the left side, which is medial, you see an area that belongs to the anterior scalene muscle. And on the right, you see the middle scalene muscle. And in between are 2 big structures. One is that red dot here, which is the subclavian artery. And then next to it is this bunch of grapes. And those are all elements of the brachial plexus. And if you look closely, you can see that these little round structures are much smaller and more well-defined than the ones surrounding them. And those are the inflamed ones. So this is all the nerves in this area highlighted, and the ones with the stripes are the ones that are abnormal. So again, just by taking this one image, you can already see in this patient that there is proximal involvement, and that is a support for your diagnostic suspicion. Okay, so sometimes if you get a patient, this is our, sorry for the EMG table, which is in Dutch, but I think you get the idea. Sometimes the diagnosis of demyelinating neuropathy is pretty clear. So we have this patient who has motor nerve conduction studies. This is median nerve, obviously, and ulnar. Long distal latencies, 4 milliseconds in our lab would be the cutoff at a 6 centimeter distance from the wrist, from the recording site. Median nerve has long distal latencies. There are low amplitudes. This is peak, so they should be like twice as high. And there are blocks if you stimulate more proximally. So in this case, this is maybe not so exciting, right? You don't need an additional tool. If the clinic also tells you it's a demyelinating or inflammatory neuropathy, you're there. But when it's not, this is an example of where ultrasound might help you make your diagnosis more certain. So this was a 38-year-old male who's had a progressive numbness, and it started actually in the upper limbs, so fingertips, hands, and arms, but also his face and feet. And he started losing his balance in the dark. And then we found he also had proximal leg fatigue and weakness when he went up the stairs, foot drop if he walked for a longer distance. He'd been seen in that hospital that everyone knows elsewhere, and there was extensive lab testing, but it was all negative. They did electrodiagnostic studies, and the report we got said sensomotor polyneuropathy, and they thought it was demyelinating because the distal limb nerve conduction studies showed a nerve conduction velocity of 35 to 58 even meters per second. Now, for us, these velocities do not indicate demyelination. There is a cutoff that says that your velocity should be less than 70% of the lower limit of normal. Because if you lose axons, you will also lose a little bit of nerve conduction velocity if you lose those big alpha-1 motor axons. So we would have a cutoff for the lower limbs of 30 meters per second roughly, and the upper limbs 32. So this is maybe just axon loss. And when we repeated it, we found no polyneuropathy, to be honest, just a unilateral slowing over the wrist of the median nerve. And the conduction velocities in the legs were a little bit slower, but compatible to axon loss. But there was slowing of the H reflexes and F responses, which in itself is not enough to fulfill the criteria. So these were the H reflex latencies. This was a normal height person, very long, but they were, well, pretty okay to recognize. And they also, appeared and disappeared with the appropriate stimulation protocol. And we had these F responses that were also prolonged compared to our normal 32 millisecond cutoff. Okay, so you think, yeah, this is progressive ascending numbness with proximal weakness. These findings might be CIDP in this patient, but we weren't sure enough. So this is one simple image from his interscalene brachial plexus. So again, you see middle scalene muscle here, anterior scalene there, and this is sternocleidomastoid on top. So we're on the anterior or lateral neck, and you see the nerve elements lying between the scalene muscles right there, and they are anatomically organized, right? So this would be 5, 6, 7, and this is 8. And number 8 is not okay. So number 8, if you measure it, you see the measurement on the right in the screen, you can see that it's over our limit of normal, which is around 13 square millimeters. Obviously, if we do an ultrasound like this, you won't just get this one image or one measurement, but we make a whole result table for you like this, where you have all the sites that are measured: cervical roots, brachial plexus, phrenic, vagus, median, and ulnar, and everything that is bold-faced is in our lab too big. So this is really a more diffuse multifocal nerve enlargement, and that confirms our suspicion of inflammatory neuropathy in this patient. Does it help you? Yes, it does. This is a study that was led by Dr. Goedee, who we'll talk to you in a minute, where they've shown that you can detect up to 25% more patients who will actually benefit from immune treatment, such as IVIG. And I think this is where the real money is. It's not about finding out a cool new technique to replace EMG. It's about detecting patients that you can actually help by providing them with the correct treatment. And if you can detect up to 25% more than you could with just EDX and clinic alone, I would think as a neurologist, you'd be happy to start doing that, right? So let's look a little bit beyond CIDP and multifocal motor neuropathy. If you would have a lot of time to scan your patient, you could scan all limb nerves and the neck, and then you will get to see this type of pattern where disorders like CIDP, MMN, but also neuralgic amyotrophy, which happens to be another hobby of mine, they all involve the brachial plexus, while the axonal inflammatory neuropathies, as in vasculitis or sarcoidosis, they don't. They usually involve distal sites and not brachial plexus. And I would ask you, if you have a patient with a proven peripheral nerve vasculitis who has involvement of that plexus, you should publish the case, because up till now we haven't seen that pattern. So let's look at some examples here. This is the phrenic nerve in the neck of a patient with acute neuralgic amyotrophy who had a diaphragm palsy. So this is the mid-cervical level, and it might be a difficult image to interpret, but here on the right, you see the nerve coming in, and this section actually is still within normal limits. This is now a longitudinal image to show you the abnormality. So you can see the nerve swelling here. There is a weird oblique line in this section, and then there's more swelling at this end. And what you're looking at here is actually nerve torsion. So the nerve is twisted around itself at this point, like that. This is very, very typical. It's actually, at this point in time, we think it's pathognomonic for neuralgic amyotrophy. So if you see this twisted nerve, in English, they call it an hourglass constriction at that point, you have just identified or confirmed your diagnosis. Here you see another one. This is the radial nerve. And this is the point where it's actually rotated around itself. And this is what that looks like under the operating microscope. It looks the same. So it's not just an ultrasound phenomenon, but it actually happens. And we think what's going on is that this nerve, because it's inflamed, this segment, it will swell up. And then if it's a nerve in a section of your body that has torsion in it, like your arms rotate or your shoulders, it will actually kink around itself, like volvulus in the intestine. In some people, it resolves spontaneously when the swelling goes down or goes away. In some, it remains, and then it becomes a really tight fibrotic segment, and you can't re-innervate. So this is actually a reason for surgical treatment in people who've had a paralysis and this type of lesion. Here's an example of a person with an ANCA positive vasculitis with involvement of the nerves. And if you have ultrasound with these cool low-flow Doppler settings like this, you can see this sural nerve being surrounded by inflamed fat tissue in the subcutaneous layer and a lot of these vascular signals in and around the nerve. So this is what an acute active segment of vasculitis looks like. I must tell you, though, that the chance of you finding this type of segment is not that big. In most patients, you just see an enlarged nerve, and then the active phase is already gone, and you find axonal loss on your EMG. But we do use this type of pre-screening if we want to biopsy a sural nerve, so we make sure that we get a segment that was affected. So for you to take, well, not home, but take it to your hospital, nerve ultrasound for inflammatory neuropathies has a really nice high sensitivity and a really good positive and negative predictive value for detecting inflammatory neuropathies. The specificity is not that high, but for that, you need to combine it with that electrodiagnosis and your clinical suspicion. So actually, nerve ultrasound and nerve conduction studies are just each other's opposite or mirror image. Nerve conduction studies are not that sensitive, but very specific. Ultrasound is very sensitive, but not that specific. So use them both to your advantage, because you will detect more people who benefit from treatment. And it's also just in the guideline of how to do a workup of a patient with CIDP or MLN. I think that sort of goes along the same line. So this would be my takeaway message. Electrodiagnosis, ultrasound, and your clinical assessment, they are really best friends forever. Use them wisely in this combination. If you want to know more, David already told us, we have in IFCN Society of Neuromuscular Imaging, it's a special interest group. It's open to everyone. You can join if you're a member of your local neurophysiology society, or otherwise, I think for $1.5 a year. That doesn't break the bank. And that's all for me for now. Thanks for listening.
Thank you very much, Nens, for this most beautiful talk. Very, very useful, practical, with beautiful images. We can have questions now. If you can have a Q&A in the site. And if not, we can go to the next speaker and have the discussion at the end. And please prepare your questions through the chat and through the Q&A instrument that we will discuss at the end. Thank you very much, Nens. It was very instructive. Great. And Stephan, you can start. We will have some discussion at the end, because particularly for amyotrophy, neuralgic amyotrophy, it's very, very beautiful images.
Oh, thank you very much, David and Nens, for this very nice overview. Hope you can all hear me quite well, and the images are now well displayed. So I'm now shifting gears towards MRI imaging and dys'immune neuropathies. And MRI imaging, like ultrasound, is to capture those patients with other disorders than you would commonly be able to detect with your routine diagnostic tools. So it's to capture the ones that are potentially treatable. And in suspected neuropathies, the diagnostic strategies are obviously on a particular alignment. Clinical features are obviously the leading part, followed subsequently by nerve conduction studies and adjunctive diagnostics. So the clinical features, as you can see here, you may all well know these, with a positive history in the family, including foot deformities and nerve palsies, lower limb atrophy present, indicating a hereditary component. What is more interesting in the ones that are later onset is the motor predominant features, including proximal and distal weakness, asymmetric weakness, as you can see here, and it can involve upper and lower limbs. What you can also have is normal muscle strength, as you can see here. Patient does pinch with the fingers, not entirely accurate, but it's just an indication of how good his muscle strength is. Then the sensory testing is abnormal. You can see here there's pseudoatetosis of the fingers due to the proprioceptic abnormalities. Reflexes were absent. And here you can see he's got sensory ataxia, which is also present when he walks. You can see here the very wide base and slow stride. Other indications that you may be dealing with an unusual cause of neuropathy are skin manifestations and other non-nerve manifestations you should look for. Then for the spectrum of immune-mediated neuropathies, you can look at whether there's motor or sensory involvement, arms and legs, and whether that's multifocal or diffuse. MMN is motor predominant, exclusive motor, of course, and then multifocal, predominantly involving the arms, but up to 1/3. The initial presentation may be in the distal lower limb. Then multifocal CADP, which previously was known as Lewis-Sumner or MATSAM, has an equal distribution in the upper limb distally, like MMN, but has sensory involvement. CADP, the typical one, is the upper and lower limb symmetric, motor and sensory, but still motor predominant. And an IgM neuropathy, which is sensory predominant and much more in the distal lower limbs. You can have position tremor and then cranial nerve involvement, particularly in CADP, and a variance of such as multifocal CADP, fault paresis in MMN and ataxia, and IgM neuropathy in some of the patients with CADP, especially ones with sensory variants. Then the nerve conductions in the demyelinating neuropathies, homogeneous conduction slowing, which was derived from several biopsies indicating the hypertrophic and the neuronal types, and hypertrophic are now known as the hereditary demyelinating and the neuronal, the axonal group, and 60% of the lower limit of normal was capable of discerning these groups, which has become, for an arm nerve that's 38 meters per second, the standard to discriminate these groups. And obviously there are intermediate phenotypes as well, but you can see very nice here, homogeneous conduction slowing, which is fairly preserved across segments and between nerves in the same limb. However, in dys'immune neuropathies, it's a bit of a different story. So the nerve action potential propagation may be preserved distally, but if there's between the distal and proximal site of stimulation disruption of the myelin, then the impulse propagation is arrested or slowed, and you may get conduction slowing or even blocking. Mind you that these are all temperature dependent and require standardization of stimulus recalling sites. And in dys'immune neuropathies, these patterns are typically focal and very patchily distributed, so you need very extensive nerve conduction studies. And here you see samples of very much prolonged distal motor latencies, segments with preserved motor conduction, but also segments with severe slowing and F-wave slowing. Again, here's samples for this conduction studies all the way up to Erb's points, so median and ulnar nerves, lower limbs again. And the guideline for CDP currently advises at least 2 limbs with 1 upper limb, and when negative, expand to the other limbs, particularly the other arm. For MMN, it's even more challenging to capture the abnormalities sometimes, so you need very extensive studies. And what you get, as you can see here, is a motor conduction block, but the sensory conduction is preserved over the same segments, and the conduction velocity is normal. And that indicates exclusive involvement of motor actions with preserved sensory function, not only distally. So in addition to these distal, so the hand muscle recordings, in our clinic, we also do more proximal recordings from the forearm and the musculocutaneous from the biceps. As you can see here, an example, the more distal recordings were normal. And in this patient, the musculocutaneous, as you can see here, a conduction block with normal sensory of the same segment. So that's all of the routine work. But what you need to keep in mind is that there's quite a bit of overlap patterns. Our colleague from Brussels, Peter van den Berg, already addressed some of these patterns, but you can divide that into distal nerve terminal, intermediate, and proximal. And the IgM and distal CDP, more distal motor latencies being prolonged, more conduction slowing in poems with a lack of conduction block and temporal dispersion, whereas MMN has conduction block, less slowing and preserved sensory. And there's motor CDP and multifocal CDP, typical CDP, and even GBS, of course, in different stages when you try to assess that. Now, when do we switch then to nerve imaging, as Nens already addressed? So the clinical features are compatible. You do your appropriate nerve conduction studies with the appropriate requirements, and they actually are negative, but you still think it's one of those treatable neuropathies. Then you would switch to MRI or nerve ultrasound. And MRI has the advantage that it allows you to visualize the MRI, the brachial plexus, and also the very proximal elements, and is helpful in evaluation of the nerve roots and trunks. The cords and divisions are a bit more difficult to assess, and I don't think they're reliable enough with the current techniques that we have on MRI. What we do need to take into account is that there's quite a bit of variation of the nerve roots and trunks. As you can see here. And some of these elements of the plexus can be aligned quite differently between patients, and also within the patient. Say left side, right side may not be the same. So what about the facts? Well, Nens already told the benefits of using ultrasound. It has a flexible field of view. Nerve size is the most robust parameter. And there are obviously quite a bit of well-established reference values, and it's a reproducible tool. MRI, on the contrary, has a fixed field of view, so you need to actually define with a radiologist what is the site that you want to visualize. Most of the standard imaging actually undergoes qualitative rating, and that's not really reproducible. You do have the advantage of dedicated sequences, so for some indications, that's a benefit. And as you can see here in the lower panel, what you can do is also do more objective measurements, but most radiologists are not used to do that, but you can refer to this paper here to your radiologist in your own setting to do that. And that actually improves the reproducibility and also the yield of MRI in suspected inflammatory neuropathies. Of course, and Nens already said that it's not a replacement. It's not something that you can use in all diseases, and it doesn't replace your clinical workup and your electrodiagnosis. Unfortunately, there's a lack of specificity, so you need to take into account radiological mimics. there are reference values, and then you've got normal values and disease-specific values. That is something important to consider. And then there are diverse protocols and diverse rater experience. So diverse neuroradiologists rater experience or neurologists rating that. And the abnormalities are often heterogeneous. So it's quite a bit of a challenge to interpret those findings without any experience. So you can see here with more advanced protocols of the MRI, maximal intensity projection. Here you can see the nerve roots in a patient with axonal neuropathy, and these panels indicate the patient with CNP with very prominent and enlarged nerve roots and higher signal intensity. The brachial plexus can also show enlargement in MMN, as you can see here, in a very more distal part in the patient, as opposed to the one with progressive muscular atrophy, so a pure lower motor neuron presentation. Also, the multifocal CNP, which is also known as Lewis-Sumner, you can also find this nerve enlargement. So MRI detects abnormalities in typical and variants of CNP, but you can also find similar ranges of enlargement in hereditary demyelinating neuropathies. As you can see between these images, these are virtually indistinguishable if you look between these cases. And Nens already illustrated that enlargement is also present in amyotrophic neuralgia, very proximal, so proximal arm nerves and brachial plexus. And if you only focus on nerve size alone, then it's very difficult to discern that from other causes, such as multifocal CADP. And another aspect is the bullseye, a very targeted sign indicating what Nens already illustrated in her presentation, the constriction of the nerve. So what should you do then in your own setting? Use at least a dedicated T2 or Dixon or STIR setting of the sequence, and ask your radiologist to look for enlargement of the brachial plexus, T2 hyperintense signal, although that's less reproducible, and preferably use objective cutoff values and measure it. We don't advocate the use of contrast enhancement, gadolinium, because there's low sensitivity, low reproducibility, and I would only advise to order that if your differential diagnosis includes other causes such as a malignancy, and to see if there's extensive involved multiplexes and other tissue around it. And mind you that these abnormalities are not specific. In most settings, we don't have standardized cutoff values for abnormal MRI, unless you use the more objective measures, which are more recent studies. And the interpretation of these heterogeneous results requires quite a bit of expertise of the neuroradiologist. And again, as Nens already illustrated, there are patterns out there. So you could, again, like the nerve conduction studies, or distal part, the intermediate and very proximal part, typical CADP, IgA neuropathy, POEMS, hereditary demyelinating neuropathies, they all have quite a bit of nerve enlargement along the full length of nerve, all up to the brachial plexus. GBS usually actually has very proximal enlargement, especially those have been documented on MRI studies with normalization over time, although we do not advocate that for the diagnosis in GBS. MMN and also amyloid neuropathy may also show nerve enlargement across the length of the nerve, probably with more severe nerve enlargement and amyloid neuropathy with increased disease duration. And again, amyotrophic neuralgia, constriction and torsion is another unique feature that may help in a subset of patients to identify those and distinguish those from other causes. Vasculitis, neuropathy, we wouldn't use MRI imaging, but we use ultrasound, and sparing of the plexus is a typical pattern for vasculitis neuropathy. So more newer techniques, you've got MRI neurography. It's very fancy. You can evaluate the nerve roots, track the individual fibers. Diffusion actual indicates more axon and radial more myelin. It can use that also in dysimmune neuropathies. And we found in a study that in patients with MMN, The axial diffusion is reduced compared to healthy controls. And in CIDP, the DTI of the nerve roots was also abnormal compared to healthy controls. So this is more experimental and still not available for routine use in research setting. So in conclusion, nerve imaging, as Nens already addressed, aids in the diagnosis of neuropathies. It complements electrodiagnosis. It doesn't replace it. You should use reference values when you do that. Those are available for ultrasound. There are fewer available for MRI imaging, but we still advocate using those. Greater experience, especially for MRI, is of influence on the results. And you do need an adequate imaging protocol. So for MRI, that would mean adequate dedicated T2-based sequences. And keep in mind that there's quite a bit of heterogeneity of the results with lower specificity. So interpret the results always in the appropriate clinical context and take into account the findings of your nerve conduction studies and laboratory results as well. So with that, I would like to conclude my part of the presentation, and then we can switch to.
Thank you very much indeed, Stephan, for this very clear presentation and for being in time. We have some minutes for discussion, and we had the first question in the chat asking to Nens normal values for nerve ultrasound in children, and she has kindly provided some papers with nerve US CSA values for children. I believe you all can see in the chat. If not, please let us know. Then we had 3 questions from the Q&A tool. I believe most of them are at the beginning for Nens. And the first one is, in your clinics, are electrophysiology and ultrasound done during the same visit by the same clinician?
No, not in the same visit. So it also has to do, I think, with your country's organization of the healthcare system and billing structure. A patient would typically come into a neuromuscular doctor on our outpatient clinic and then be referred for those additional diagnostic tests. And EDX and ultrasound are 2 separate tests, but they literally live on the same floor. It's just 1 door away. And we do have an ultrasound machine in the EMG room to, localize muscles if we need to stick a needle in specifically, or if we're not sure about something, we might scan and add the anatomic info. So we often integrate them in a small part, but if you really get a diagnostic ultrasound, we would take you to a different room. We do try to provide some convenience for the patients by doing all of that on the same day, but that's just practical.
Okay, I see that Stephan is writing an answer the Q&A tool. If we wait a little bit for him to conclude. I don't see your answer, Stephan.
No, I don't.
Oh, so in our clinic, we do have the luxury that we have the opportunity to swap the machine between the 2 EMG rooms. And we've got trained technicians that can do both the electrodiagnosis and ultrasound. I often do it myself as well. So depending on the amount of time that we have, obviously we are training facilities, so we would have trainees or fellows do the first bit, and then we would amend. And sometimes we do it just fully ourselves. So it's usually a mixture. It's very nice. And it is very much a nice learning curve for trainees and fellows, as well as technicians in training, to use both techniques to see how they kind of complement and what kind of different information you get from the functional aspect of electrodiagnosis, and then what kind of other answer you get from your morphology using ultrasound.
Okay, thank you, Stephan. And our question is first to Nens. Is it possible to do ultrasound of proximal nerves like long thoracic nerve and winging cases, or inferior gluteal nerves waddling cases?
Yes, I think there is. I don't know if you are familiar with the 1970s book, The House of God by Samuel Shem. It had a maxim in it saying there is no body cavity that cannot be reached with a 20-gauge needle and a strong arm. I think you could say the same about nerve ultrasound. With experience, you can basically scan almost every nerve in the body, except those that are behind the bone or in an air cavity. So you can scan the long thoracic nerve in the neck and the phrenic nerve in the neck and the vagus, etc., but you can't follow them into the thoracic cavity because of the lungs. And the same is for the deep lumbosacral plexus elements that are in the pelvis behind the intestines, for example. That is a region I can't reach. But up to a couple centimeters proximal from the inguinal ligament following the femoral nerve for the first few, yeah, sure. So what it does take is practice.
Okay, thank you. Stephan, you can speak, so don't.
Oh yeah, so in our setting, we also use ultrasound for most of these very proximal and smaller nerves. You can also use MRI. The advantages of MRI is that you can, in addition to the nerve itself, you can also visualize the muscles with different sequences. Obviously, you can also visualize the muscle with ultrasound as well, but you don't have the luxury of different sequences. Having said that, it depends on the availability and experience. If you've got a well-trained radiologist and musculoskeletal assessment, then we'd certainly try to see if you can get enthusiastic and use both techniques, preferably. MRI is probably very much available. Ultrasound may be less experience in some settings, but we can use both. And if you use, if you want to assess something like the lumbosacral plexus, then you would switch to MRI because that's too remote to access with ultrasound.
Okay, this is a wishful question. Is it possible to recognize nodal paranodal neuropathy with ultrasound? Thank you.
I think Stephan has the definite answer, but I think this is circling back to the specificity and sensitivity discussion about ultrasound. It's very sensitive, but it's not as specific that it can do this, and the resolution is not down to the level of the internode segment. So, Stephan, if you have some things to add about pattern, etc., please do.
Thanks. I think it is indeed a lower specificity in the overlap. It's inflammatory. If you go back, these nodopathies used to belong to CADP. In the recent guideline, they are isolated as a separate entity. There are pros and cons to that. But you should consider those previously as CADP with unusual kind of course. And as such, I don't think you can reliably distinguish those. The only test that can distinguish those, because we previously weren't able to do that clinically, nor with electrodiagnosis, use your appropriate ELISA assessment and confirmation with another technique that there is nodal antibodies, paranodal antibodies present in those cases. So ultrasound, unfortunately, we cannot help selecting patients which are eligible for nodal antibody testing. That's still a clinical clue. Other course than CADP, other response to therapy, and you still think it's a treatable neuropathy, then go and try tests for nodal antibodies.
Thank you, Stephan. Thank you both. Another question: is it possible to in entrapment neuropathies where ultrasound is positive, but EDX negative, which should guide the management?
The clinic should guide the management, actually. That would be I think, the most important point to take home. But we know that, for example, in simple carpal tunnel syndrome, if you do ultrasound, you will find 9 out of 10 people with surgically confirmed entrapment. If you do EDX, you will find 9 out of 10 people with surgically confirmed entrapment, but they will not be the same 9 people. One of them will be different. So they actually, if you scan 100 people with both ultrasound and EDX, you will find 95. And I think in cases where there is a discrepancy between the two, you need to make the clinic, the presentation, the symptoms prevail, and then use that test to augment or refute your diagnosis. It's unfortunately not a litmus test or black and white decision.
Clear. This is a question for Stephan. What is your opinion on the role of the ultrasound in differentiating GBS from CIDP, particularly in patients with a slow onset presentation suggestive of acute onset CIDP, ACIDP?
Yeah, thank you. We had quite extensive discussion about imaging in GBS and in cases where you suspect acute onset CIDP, so more aggressive CIDP. With the initial presentation, we actually agreed as a task force that we shouldn't use MRI because there's no reliable distinction between those disorders. There are no studies actually comparing the yield of MRI or ultrasound between those disorders, just limited to the brachial plexus. In our experience, the yield of imaging abnormalities in GBS is already low. In contrast, what you could do, there are still a few studies, so they need confirmation. Ultrasound of the brachial plexus and arm nerves. So if the enlargement extends beyond the brachial plexus, that would indicate a very much more chronic disease process, especially since the arm nerves are more distal from the very proximal inflammation. As well, there's the consensus that's the most arguable, the most kind of true side of inflammation in GBS, where in CNP it's much more diffuse and more kind of progressive enlargement towards distal is such a longer disease process, so that indicates it's more acute CADP. So our proposal was to advocate do more intensive monitoring of those patients rather than directly switch to chronic treatment, because you're not sure just by using ultrasound alone. So it's shift of focus rather than already shifting diagnosis. So it's an indication. It's not a confirmation that it's acute CADP.
Clear, thank you. Another question by Angela Puma. In your opinion, is there a difference in pattern US between multifocal CIDP and typical CIDP? And what do you think about the alteration on the internal nerve structure?
I think this is the question for Stephan mostly.
Yeah, I don't think you can distinguish multifocal and typical CADP just by ultrasound alone. There's a trend towards more regional and focal enlargement in a more asymmetry in typical and multifocal CADP, but it can also be quite extensive and more symmetric, especially with longer disease duration. That's not infrequent in patients with such rare diseases, which are often mistaken for focal neuropathies initially. And the typical CADP, the literature is skewed towards more kind of extensive symmetric abnormalities, regional, or can be even diffusing up to 1/3. But there are patients as well in the distribution of the abnormalities, which are to the lower end, where there's more asymmetry and more regional abnormalities. So it can be very asymmetric as well. So I don't think there's a reliable distinction between those groups based on nerve size. If you look at the internal architecture, there's a lot of opinion about what you should think about that. There's not so much evidence to support it. We do think that there's edema, that there's fibrosis, and that you have different stages between different patients. Unfortunately, most of the pathology associations are from distal sensory nerves in the leg and not from the mixed human arm nerves. So we don't know actually what happens in those patients. So, and the other thing is that assessing aspects such as fascicle size and echogenicity are far more challenging. And well, for now, they're not really suitable for routine clinical practice. So you could include them in the report, but I wouldn't rely using those descriptions to arrive at the diagnosis of CADP or MMN.
Okay, we have time for the last question, and I don't know if people have the possibility of taking the DOIs of the papers. I'm not sure. We will try to provide you later. The question is, thank you both for excellent presentations. Opinion I share. You've shown that patients with CMT1A have enlarged nerves on MRI scan. Is the same true for US ultrasound? Can ultrasound distinguish between inflammatory and inherited demyelinated neuropathies? Very important questions, recurrent.
Yeah, so it's the same for, if they are large on MRI, they are large on ultrasound. That's just a structural property that you're assessing. Can ultrasound distinguish? Well, there are some international scoring systems, specifically from the group of in Tübingen, Professor Grimm, and from Bochum, that have made a scoring system where you measure multiple nerves, and then based on the cutoff values that they put in there, you can make this distinction. To be fair, in practice, usually the distinction is already made in the initial presentation, again, clinically. So, and I think the drawback of the scoring system would be that some of the, I should say this differently. Most of the nerve disorders that we know make larger nerves. The only disorder that we know that gives you smaller nerves clinically is sensory neuropathy, because then you lose 50% of your axon content almost in a nerve. All the other disorders, you get larger nerves because of inflammatory responses. So finding a large nerve, again, is very sensitive with a cutoff value, but it's completely non-specific if you don't know the clinical scenario, if you don't have a pattern of involvement, or the time course or a family history even. So just by looking at the nerve, for example, in the brachial plexus and seeing that it's enlarged at root level will not make a distinction between a neurofibroma, a schwannoma, maybe a CIDP or HMSN. You really need to collate all those info streams to make that diagnosis. So I think you can, to help you if it's really difficult, you might use those scoring systems, but please keep in mind that they are only made for very certain clinical scenarios. And if you don't know what the patient has, you should not use them because not every diagnosis is in there.
Is it true that it's homogeneous enlargement is a little bit in favor of demyelinated CNT versus non-homogeneous enlargement in favor of CADP?
Yeah, I think that is well put, but you also have CMTs where the enlargement is non-homogeneous.
Yeah, that's true. That's true.
So it's again, if you see it like the vasculitis, right? If you see the inflamed nerve, it's very typical, but it's only a minority of the patients that will show that particular pattern. And I think it's the same with the totally diffuse homogeneous enlargement. I don't find that to be very common. I don't know if you do, Stephan, but...
Yeah, so the studies that have done and showed their ROC curves, there was a capacity to distinguish those, but it's in a very kind of subgroup. In an individual patient, you can rely on distinguishing those reliably because there's quite a bit of overlap. So there's CADP with diffuse enlargement, and there's CMT, also CMT1 with more regional and multifocal enlargement. And arguably, there's also a relation with disease duration. If you look in children with CMT1, you see that nerve size increases over time. So the dysmyelination actually kind of builds up and yields more large nerves over time. We don't know how much that increases beyond the adolescence age, but there's certainly evidence that in children, nerve size will increase over time. So what you could do if you think the patient has a CMT1A, you could do if the child is very anxious for having an EMG screen with ultrasound first, and then advance to genetics, and if it's still uncertain, then add electrodiagnosis. But if you want to have the complete context, then always combine with electrodiagnosis. I think that's the most safe route.
Okay. Thank you very much, both. We are running out of time, so we need to close, but it was very, very useful for everybody. We thank you a lot. Remember that the recording is available on the EURO-N YouTube channel. Thank you both. Thank you all for attending. Bye-bye. See you.
Thank you.
Thank
Bye-bye.
you. Thank you.